Thank you very much for the invitation and give us opportunity to share the efficacy and safety data from our PD-L1 antibody. Okay, it's my disclosure. So this one everybody knows. We hope we can restore HBV specific immunity. Okay, I think our previous speaker talking about the Work-Chuck model, I guess this is one of the best models to show immunotherapy works. So here, I think the take-home message is when you have a lower baseline S antigen, the responder rate is higher. Okay, let's talk about our antibody. ASC22 is maybe the only sub-Q antibody in the HBV area for anti-PD-L1 and is humanized single-chain small antibody and is the first sub-Q antibody proved for the oncology indication. I believe Roche has second one just proved. So compared to a traditional antibody, the size is small, half, and sub-Q, of course, and high fidelity and the room temperature stable. And also immunogenicity is a little bit lower. Okay, so before we started clinical trial, we did ex vivo study in the HBV, in the PBMC from HBV patients. So as you can see here, ASC22, a sub-Q PD-L1 antibody, can activate HBV-specific T cells. If you look at interferon gamma, and also same results as we observed in the Work-Chuck model. Here is ex vivo in human PBMC, lower baseline antigen, which less than 100 IU per ml, had a better interferon response. Of course, this is not a big sample size. So based on that, we did 3 clinical studies for this antibody. First is phase 2A. So phase 2A is a single dose escalation, 9 patients. And we start with 0.3, 1, and 2.5. So give you the dose strength compared to oncology. 1 milligram per kg dose is 1/5. 1/5 of oncology dose, which is proved for oncology indication. And 2.5 is half of oncology dose. So this one is published at the 2021 liver meeting. So after that, we chose 2 doses for a quite large phase 2B study, which enrolled 149 patients at 2 different dose levels. One sub-Q every 2 weeks, and the second dose is 2.5 milligram and every 2 weeks. So here's the baseline compared to 2.5 milligram per kg and pooled ASC22 and also pooled placebo. They are quite comparable among all these groups. Okay, let's look at data. First, we're happy to see first time for this antibody sub-Q can induce HBs decline. Okay, if we look at the comparison between ASC22 treatment group and placebo, of course, we see statistically significance. However, if you look at the 2 different doses, we didn't see the dose proportional response from 1 to 2.5 milligram per kg. So we don't know why, but maybe it's immune activation or restoration or reached the maximum at 1 milligram, because we have PK data to show at the 1 milligram we reach the antibody concentration for 90% receptor occupancy. So 2.5 does not add much more. Okay, so if we group 1 milligram by different baseline HBs antigen levels, that's very interesting. So if we look at the S antigen less than 100, we see almost 1.5 log reduction at week 24. If we look at the S antigen from 100 to 1,000, even greater, we didn't see much S antigen reduction. So that gives us the kind of consistent results as we observe in the human PBMC ex vivo study and also the woodchuck model with woodchuck anti-PD-L1. Okay, so out of 7 patients with baseline S antigen less than 100, 7 of them showed S loss at end of treatment, which is 24 weeks. And we also follow up for 24 weeks. There's no rebound. So the third patient also has no rebound. So we believe, look like we may have 3 patients achieve the functional cure. So that take-home message is, for some reason, we didn't understand well. Seems to me, once patient on the ASC22 monotherapy achieved S antigen loss during the treatment, on treatment, there's no rebound. Of course, the sample size is very small, very small. Second, we do have ALT, a flare, as you see here, kind of linked to the S loss. And we see some trend of interferon gamma and IL-2, but nothing significant. So I guess most significant biomarker we observe is on-treatment ALT flare. So if we group them in different ALT flare group, for example, concurrent ALT-AST, most significant S antigen reduction. Then followed by ALT. Then if we look at all, we see minimum S antigen reduction. So this ALT flare is about 20%. Okay, out of 2 patients out of 3 patients who achieved the functional cure had a ALT flare. So, of course, we don't know is it's good one or bad one, but at least we don't have that side effect which patients say withdraw or some kind of grade 2 or 3 side effects, all grade 1 side effects for the patients who achieve the functional cure. Okay, so if we look at the safety, I guess everybody pay attention to safety. So safety is really, I think is well tolerated. All the side effects are mild. So let's pay attention to IRAEs. Of course, we see much more IRAEs compared to placebo group. For ALT-AST increase at 1 milligram, we see about 23 to 28%. At the 2.5 milligram, we see less, 13.6%. Don't know why. Maybe, as I mentioned, we reached the maximum immune activities at the 1 milligram per kg, because 1 milligram per kg show 90% receptor occupancy over 1 month. And if we look at thyroid dysfunctions, that means hyper or hypo, we see those proportional increase. At 1 milligram per kg, about 11.7%, and 2.5 milligram, 32%. So that's one of key reasons. In addition to efficacy reasons, we choose ASC22 1 milligram per kg for the extension study. But interestingly, if you look at oncology setting, for our PD-L1 ASC22, we don't have pneumatitis, and we don't have colitis at all, compared to Keytruda, we did see 3% or 2% such IE, immune-related IE. So maybe because the size of antibody is small, so we have less immune responses, especially for the colitis. Okay, so based on that, we started the extension study focused on patient population with S antigen less than 100. So the idea behind this, first, we may get approval in China. Second, most of sRNA, ASO, and others can bring S antigen less than 100. So if combined with this antibody, if we can prove in 100 baseline it works, then combination could be a very good idea. So we're going to have a detailed interim analysis presented at this meeting on November 13th. But the bottom line is, right now we do have interim results after 24-week treatment. We got 19 patients finished 24-week treatment. 4 out of 19, 21% achieved S loss. So we're still in follow-up. We don't know if we can achieve functional cure yet. So the take-home message is sub-Q, easy to be administered. And also ALT flare, of course, is a biomarker for the potential functional cure and S antigen, and extension study is ongoing. I guess one of my last slides is what's next. So there's a lot of combinations people talk about. I'm not going to go through details. So lastly, I want to thank everybody, all the investigators, all the patients. Thank you.